everyone. Let us discuss about imaging in COVID-19. By the end of the discussion, we shall be able to answer three questions. What to expect in imaging in case of COVID-19 pertaining to pulmonary manifestation. Secondly, when to do imaging. And finally, which is a preferred modality. So we know that we are in the middle of a pandemic hit by the novel coronavirus, to be specific, the SARS-CoV-2 strain. And the route of transmission is by droplets and aerosols. And the brunt of the disease is borne by the principal organ, which is the lung field. Why so? Because novel coronavirus has great affinity to ACE2 receptor, which is abundantly found in the lung parenchyma. So, the most commonly affected site is the lung parenchyma. Now, coming to the clinical manifestation, it ranges from fever, sore throat and cough, to the fatigue, myalgia, and the like. And regarding radiological aspects of COVID-19, before going to details, let's have a clear-cut idea of what is normal and how does the abnormality come about. So this is a normal radiograph of chest where you have the clear lung fields, black lung fields, and in between these linear radiodensity, these are the vasculature. And normally as you go from top to bottom, it increases intensity in number, and from center to periphery, it decreases. This is the normal pattern. This is the region of heart in the vessels, and rest are the bones. So why does the lung give such an appearance? This is because the lung is filled or made of number of alveoli together, and these alveoli has got air within. So when the X-ray beam passes through the air, you get black lung fields. Supposing instead of air, the air in the alveoli is getting replaced by fluid. Why the fluid? We know that when any foreign antigen enters the body prepares itself by activating the defense mechanism, which involves inflammation. Inflammation involves hyperemia and infiltration of cells. So the air is replaced by fluid. So no longer the lung parenchyma is aerated, but you get multiple opacities like this. This is what we're gonna look for. So at hand we have two modality. One is the X-ray, the other one is the CT. So let's take them one by one. So before going into the assessment of X-ray, we should have a clear-cut idea about the technical parameter. So remember, before going and reading an X-ray, read the patient clinically, read the technical parameters. Otherwise, you may end up in trouble. We know that the normal X-ray is taken in PA view, where you have the X-ray tube here and the rays are entering from back of the patient and exiting through the front, where we have the film, the receptor which captures. But think of situations when the patient cannot be positioned in a PA view, as in cases of sick patients in ICU, sick patients who cannot be shifted, or in patients in isolation where the patient cannot be brought to the X-ray room. Typical cases the COVID pneumonia, COVID case, pandemic, where the disease is rapidly spreading and we have to contain. So we are going to the patient and obtaining the radiograph. In all those scenarios, we are going for a AP film, where the X-ray tube is in the front of the patient, beam is entering the patient's chest first, and then it is going out. So, if you were to obtain or compare two films, one on the left and one on the right, which is normal? I'm going to tell you both are normal. Why? This is a PA film and this is an AP film. So in PA film, straight away you can say it's normal. Normal black lung field, everything is normal. But here you may have to take a second look. So this is because of the technical parameter, technical things coming into the picture. You're getting slightly large appearing heart. It is not enlarged. It is giving a radiological appearance of magnification. And there are so many other changes. I won't be going into the detail of that. So remember, whenever you're assessing a radiograph, assess the technical parameter. Only then go into the pathological analysis. So yet another example is this film on your right side. What is strikingly different from this one. This is a PA film. This is an AP film, a portable radiograph. What you can see is the lung fields are more hazy. This is due to poor inspiration of the patient. So when the patient is too sick in an ICU, you cannot ask the patient to hold the breath. Even if you ask the patient to hold the breath, they may not comply. So as a result of which the lower lung zones may appear hazy. And apparent cardiomegaly. It is apparent cardiomegaly. It is not real cardiomegaly. It is due to the magnification. You feel that the heart is enlarged. In addition, for people who are trained in reading radiograph, immediately one may note that the right hilum appears to be prominent. But before attributing it or stamping it as abnormal, look at the technical parameter. If you look carefully, this is the spinous process. This is the middle end of the clavicle, whereas the middle end of clavicle is over here. Look at the distance. It is not symmetrical. In ideal situation, it should be symmetrical. If not, it means the patient is rotated. So this prominence of hilum can be attributed to technical malposition of the patient. The patient is not projected correctly. So before going to reading the radiograph, read the patient clinically, read the technical parameter, or you may end up going wrong. Now, regarding the chest radiograph manifestation, so let's see them one by one. Don't be surprised if I say that in up to 63% of cases, the radiograph can be normal. Now, coming to the common findings. What is consolidation? What is consolidation? It means there are dense infiltrations within the lung parenchyma, and so dense that it is obscuring the lung markings. And revisiting the MBBS days, we know that we have learned that consolidation, the hallmark is presence of air bronchogram. So remember, consolidation is a radiological entity. It's just a finding. It is not the diagnosis for the patient. You have to find out the etiology for consolidation. So analyze or try to understand that a patient with any sort of infection, bacterial, viral, fungal, anything can present with consolidation. Or a patient with pulmonary hemorrhage, too can present with consolidation. Patient with pulmonary contusion after road traffic accident can present with consolidation. Or a patient even with tumor, typically the adenocarcinomas, can present with consolidation. So consolidation is not the diagnosis. That is not going to bring any useful parameter to the patient. So you have to find a clue of what is causing consolidation. For that, by studies, we have to look at a pattern. So by study literature review, we have seen that peripheral, bilateral lower lung zone predominant consolidation favors one of the imaging aspects in COVID-19. Now let's see the next finding, which is a ground glass opacities. So what are the ground glass opacity? It means there are lung infiltrations, but they are not so severe, so dense that it is not going to obscure the lung markings. You can still see the lung marking. And like consolidation, it is a radiological entity. You have to go for etiology. What is etiology? So if it is peripheral, bilateral, more affecting the lower lung zone, again you can have a slightly higher possibility for COVID-19 manifestation. Now another pattern of opacity is the interstitial pattern. What do you mean by interstitial pattern? First, so for that, let's go to the anatomy. We know that the lung is made of alveoli. Many alveoli club together to form a lobule. And what is peculiarity of the lobule? The lobule is within the confines of connective tissue framework, connective tissue septa, which harbors the vessels, which harbors the lymphatics. What if the inflammatory process is concentrating in the septa? What will happen? There will be interstitial opacities like this, linear shadows, and multiple nodules. So you get typically reticulonodular opacities. So the zoomed in view showing linear shadows, and also you are getting multiple tiny opacities. So diffuse reticulonodular opacities is yet another prescribed pattern in COVID-19. And as said, the opacities tends to be peripheral, that is in favor of COVID-19. But as the disease progresses, more of the lung field can be involved, and you can get diffuse opacity. What type of opacity? Diffuse ground glass, diffuse consolidation, or diffuse interstitial opacities. All these are described. And a word about pleural effusion. Pleural effusion is seen in a subset of COVID-19 patients, but it is usually seen after third week, and it is reported in about 13% of cases. So rather than a primary manifestation, it is taken as a complication of COVID-19. So how can you identify effusion in the radiograph? You look at the costophrenic angles. Is it seen? No, it is blunted. It means the patient is having effusion. And rarely, very rarely, pneumothorax, air within the pleural cavity, has also been described. So these are the important radiological features in chest X-ray in relation to COVID-19. So that is not enough. We have to look for the temporal progression. That is, in what stage of infection, what are the manifestations that you expect, the temporal progression. So I'm going to show you one case of a 70-year-old male. This is a case taken from literature who had complaints of fever and sore throat. And in this current setting of pandemic, they tested for RT-PCR for COVID and it came to be positive. However, on the day 4 of the radiograph, when the radiograph was taken, he had mild symptoms. What you can see peripheral ground glass opacities bilaterally. On day 7, a radiograph was repeated because the patient was becoming worsening of breathlessness was there. So, just reflecting the clinical manifestation, what can you see? You can see more and more opacities in the radiograph by day 7. Now, a repeat radiograph on day 11, what is seen? As compared to day 7, there is mild clearing of opacity. But what additional features has come? You're seeing slight new reticular shadows, linear opacities. And by day 15, more of the opacities have resolved. There is a resolution of opacities. So, this shows that even when the lung is filled with infiltrates, and in due course of time, if the patient is clinically improving, the opacities can resolve. So this is a statistics taken from one of the studies conducted, and here they have clubbed the radiological features with the duration of the illness. So in the initial 5 days, 25% of cases had normal chest radiograph. And if we were to compare all the stages, what is more common? Ground glass opacities were the more common findings. And by day 18, the many symptoms, many radiological findings have been resolved. Many patients had a normal radiograph. So that is a expected pattern. Now coming to case 2, this is a case of a 55-year-old male who had cough and fever, sore throat, and in the setting of pandemic, they tested him for COVID-19 and it came as positive. So initially, no imaging was done because none is required. If the patient is okay, mildly symptomatic, no need of any imaging. But on day 5, he developed dyspnea. So what did they do? They took a radiograph. So what is the finding that you see? This is a radiograph taken from the literature in one of the studies. What is the finding here? You can see an abnormal shadow here. So first question, is it normal or abnormal? Here comes the significance of reviewing the technical parameters. Look at the radiograph. What is striking? There is gross rotation. The spine is over here, the clavicle is over here. The patient is rotated to the right side. That is why the mediastinum is having a distorted projection and it is looking abnormal. So remember, this is not an abnormal finding. This is an abnormal projection of the mediastinum. So this is normal. Now, normal means normal due to technical inadequacy. Now, looking at the lung fields, what am I seeing? Mild opacity is seen bilateral lung zone. So I'm still confused. Is it normal or can I attribute to technical error? So what happened? They went for a CT thorax. Okay, this is the HRCT cut, coronal image. What are you seeing here? Bilateral basal area, left side is normal. So this abnormal haziness that you can see, that is due to poor respiration. But on the right side, I'm seeing subtle ground glass opacities. So these shadows may be significant. But what is striking here? We failed to pick up the opacity seen in the right upper lung field. The right upper lung zone, in the right upper lung lobe, what am I seeing? I'm seeing haziness, ground glass opacity. Now let's go back and review the radiograph. Retrospective review. Yes, I can make out few opacities. Compare with opposite side that is not seen here. Look for the loss of symmetry. So retrospectively, I'm seeing some opacity here. So what does this prove? It proves that CT has got much more sensitivity than X-ray in picking up findings. So let's discuss CT features of COVID-19. So going by the features, like in X-ray, you can know that all we're gonna see are infiltrates. So some we're going to check for patterns and going to classify those features seen in more than 70% cases of COVID-19. We may call it more typical or high probable findings. This category. Or those seen in less than 10% of COVID patients, very atypical. So very unlikely, and those in between 10 to 70% of COVID positive patients. So they come under the indeterminate category. So before going to the imaging, let's have a basic idea of how the normal CT should look like. So this is an axial cut, and this is a lung window setting, which means that the lung will appear black, and all other structure, the mediastinum, the vessel, the bone, everything will appear white in lung window setting. And within the lung, what I'm seeing linear white structure. Are they abnormal? No. These are the normal branching vessel. This is the normal expected finding. And these tubular white areas, these are the bronchi. So coming to the described or the said findings common COVID-19. What do we have? We have the ground glass opacities, which means you've got opacity which is not obscuring the lung markings. You have an opacity here, but I can make out the vessel. So these are ground glass opacities. Now, what are the patterns of ground glass opacities described in COVID-19? That is of great significance. They tend to be rounded. See? They tend to be multifocal. One, two, three, four, many more. Okay? And they tend to be in peripheral distribution. That is yet another feature supporting COVID-19. And what else is seen? They tend to be evolving, they tend to coalesce together, and rarely they can be unilateral, rounded ground glass opacities, which can be unilateral. These are the high probable findings in COVID-19. Now coming to the second imaging feature, which is a crazy paving pattern. What do you mean by crazy paving? You're getting a ground glass opacity, and in addition to this, the ground glass opacity is bordered by linear shadows. So let's take them in detail. So this is the structural model or diagrammatic representation of lung lobule. So we know the basic unit is alveoli. Many alveoli grouped together will form an acini, and many acini will form a lobule. And classically, the lobule is bounded by connective tissue septa, through which runs the pulmonary vein and lymphatics. So if the infiltrates are concentrating within the septa, what will happen? The septa will begin to thicken. So that is exactly what you're seeing in the crazy waving pattern. Look at the ground glass opacity and look at the border thickening of the septa. Just like the crazy paving, okay? Crazy pavement, just like that. Now another common finding, typical for or very commonly seen in COVID-19 is the reversed halo pattern. What do you mean by reversed halo pattern? It means that there is a ground glass opacity, and surrounding that you have getting consolidation. Consolidation in a perilobular pattern. A lobule here, perilobular pattern of consolidation. Central ground glass and perilobular pattern of consolidation. More images supporting this. See? Like this. And finally, typical consolidative pattern where you get dense infiltrates obscuring the lung markings. Very important. And of great significance is the recently described vascular dilatation that you can make out within the opacity. So I said in the ground glass opacity, if you can see the vessels are very prominent. That is a supportive feature. Supportive feature of COVID-19 lung manifestation. And yet again, another prescribed finding is traction bronchiectasis. Why traction bronchiectasis occurs? As I said, this is basically a lung injury. The lung manifestation is a lung injury. You're getting an insult, the body is trying to attack. As a result of it, you're getting a lot of inflammation and inflammatory cascade and injury. But once the injury has occurred, what does the body try to do? It tries to heal. And like in any place in the body, healing is by fibrosis. So what will you get? You will get traction bronchiectasis. And For completion's sake, another commonly said finding are linear opacities. So in the periphery of lung, you get patchy opacities like this. These are another important features that you can see in imaging in COVID-19 patients, typical lung manifestation. So again, you have to know about the progression of the disease. That is very important. Progression is very, very important. So we have clubbed the imaging findings and we have tried to correlate with the disease stage, the day of illness. And hence we have the early stage, you have the progressive stage, you have the peak stage, and finally you have a late stage. So in the early stage, day 0 to 5 days of illness, if you were to obtain a CT, what will you expect? You can get peripheral ground glass opacities. Very common finding. And further progressing between day 5 to 8, if you were to obtain the CT, what will you get? You can get crazy pavement pattern and more evolving groundless opacities. And remember the peak stage. Peak stage comes in day 9 to 13 of illness. What will you get? Lots and lots of lung infiltration, lots and lots of consolidation. They're coalescing together, evolving over time. And finally, after day 14, once the disease comes down, you can get two features: either complete resolution of the lung infiltration, no longer you can get the infiltration, or the patient may go for fibrosis. So, recently, literature is coming up with lots and lots of cases of post COVID fibrosis. Very important. Just knowing the finding is not enough. We should be aware, we should be alert regarding the complication. Why? As general practitioner or as first line COVID warriors, you have to always keep in mind the possible complication. So I'm going to discuss three important complications. One is the ARDS. Let's take it in a case-based approach. A 79-year-old female complaining of fever, cough, and chest pain for 3 days. COVID positive status. It is a COVID positive case. Say suddenly she developed breathlessness and she began to desaturate by day 8. So they went for an imaging. First an X-ray followed by CT. What is typical here? In the lung, there is diffuse opacity. Right lung is almost gone. Left lung, what am I seeing? Mild sparing in the upper lung zone. So there is diffuse opacity, both central and both peripheral. Okay? And on CT, what am I seeing? The same thing. I'm seeing central manifestation as well as peripheral opacity in terms of ground glassing and in terms of crazy paving. Now, can I just brush it off as saying, yes, diffuse opacities? Very well said in COVID 19. No. So, classical teaching in MBBS days is a patient with breathlessness, hypoxemia, and bilateral chest infiltrates, predominantly perihilar, with a normal heart. It should always ring a bell. ARDS. Very, very important. Why is it important? Because the management, the ventilator setting is different. You have to go for prone ventilation. So you are getting a patient encased in the status of hypoxemia with bilateral lung infiltration. Even in COVID-19, you have to expect the complication of ARDS. And there is a slight difference between COVID-19 ARDS and other ARDS. We know that ARDS is a complication of many lung diseases. It is a complication of infection. It is a complication of inhalational injuries. It is a complication of trauma, complication of drowning. But in most of the viral pneumonia, going in for ARDS, you expect ARDS to develop within 5 to 7 days of illness. Typical example, leptospirosis. But what about COVID-19? ARDS is a late manifestation. You normally expect after day 8, a patient getting bad, going hypoxic, and bilateral chest infiltration. Keep in mind ARDS. Next complication, what I'm going to say is about pulmonary thromboembolism. So let's take a case from the literature of a 75-year-old patient complaining of fever, chills, asthenia, and on examination there were inspiratory crackles. So it shows that there is some lower respiratory tract infection involvement. Apparently, the patient was COVID-19 positive. Initially, the respiratory rate was normal and oxygen saturation at room air was maintained. But on day 4, what happened? The patient began to desaturate, sudden breathlessness, tachycardia, tachypnea. And of great interest when we were going through the blood sampling was what? Elevated CRP and D dimer. So remember a word of caution here. In COVID 19, if you were to go for blood parameters, elevated CRP and elevated D dimer is expected. But very, very, very high values of D dimer, you have to always keep in mind the complication of pulmonary thromboembolism. Okay, that's very important. So, a CT thorax was taken. Why? Because the patient was sinking. And what do you see? You see bilateral chest infiltrates, consolidation, ground glassing. And since the D dimer was very highly elevated, they went for pulmonary angiogram, CTPA. So normally in COVID patient, when you're going for CT thorax, you go for HRCT, plain CT. But they had high suspicion of pulmonary thromboembolism, so they went for CTPA. And luckily, we were able to detect the thrombus, the filling defects within the vasculature. So but how did the plain CT appear? Just like any infiltrate. So it's very difficult to differentiate. So you should have a high clinical index of suspicion. And the third important complication we should always be aware of is barotrauma. This is particularly important in ICU setup in patients on positive pressure ventilation. So this is a patient, 64-year-old male, intubated. After 4 days, what is seen? There is air within the pleural cavity, pneumothorax. It is a barotrauma. Yet another patient, 20-year-old, intubated, and after 5 days of admission, what do you see? You can see lucency outlining the heart. This is not expected. It is an air in an unexpected location. Where? Mediastinum. So it's a case of pneumomediastinum. So these are all expected complications of barotrauma, of positive pressure ventilation. So by this stage, I know most of us will be confused, pumped up with lots and lots of information. Chest X-ray finding, CT finding. So if one way to ask you, what have you taken from this topic? As a general practitioner, what should I know? We have already seen the findings, expected findings. But the most pertinent question as a first line COVID warrior is when to do imaging. When should I do imaging when I see a COVID positive patient? First question. I have a COVID suspect patient, a contact patient, presenting with symptoms. Should I use imaging as a screening test? Answer is big no. Imaging is never done as a screening test. So what about diagnostic test? Lots of typical findings. Can I use it? Again, a big no. So imaging is never used as a screening or a diagnostic test. So, another question. I have two patients, both are COVID positive. One patient is asymptomatic. Should I go for imaging? No. He has no symptoms. Then why go for imaging? No need at all. No, the answer is no. Then the patient is having symptoms. So, the next question is grade the symptom, grade the patient in severity. Mildly symptomatic? No need of imaging. Moderate to severe? Yes, you may go for imaging. So, again, a question. Can I do X-ray or can I do CT or can I do any form of imaging as a baseline status to assess the pulmonary involvement? The answer is yes, you may. It is a recommendation. It is not a must. It is a may. But for all patients, no. Only for those who are morbidly obese, you may. Or those with comorbidities, hypertensive, diabetic, cancer patient, renal disease, immunocompromised. You may go for imaging to have a baseline pulmonary status. It's not a must. So the question comes, which one? X-ray versus CT. CT is more sensitive. So shall I go for CT? The answer is no. Always you have to go for radiograph. So, doctor, can I shift the patient to the chest X-ray room? No, that's a big no. You have to go for portable radiograph. Shift the machine to the patient. Try to contain the spread of the disease. Okay. So whenever imaging is indicated, go for portable radiograph as a first line modality. So a question comes, then what is the role of CT? Why do you need CT? Three specific conditions. If the patient is worsening from bad to worse, the patient is sinking, you have to look for extent of involvement. You have to rule out any complication. You have to rule out any alternative diagnosis. Yes, you can go for CT. Or if the chest radiograph is equivocal, is there opacity? I am doubtful. I don't know. Maybe there is, maybe not. Again, you can go for CT. Or you're having high index of suspicion, suspecting complications like pulmonary thromboembolism. Yes, you may go for imaging. Now, finally, a big question comes. I have a COVID 19 positive patient. He had a very eventful admission. He was breathless, chest radiograph, serial radiograph showed progression, and now patient is clinically fine. Now I'm planning discharge, but let me look for radiological clearance. So shall I go for imaging? The answer is no. At time of discharge, to look for radiological clearance, it is not indicated. Imaging is not indicated. Go for discharge a patient if the patient has turned negative from positive and is fine. Okay? No need of imaging at all. So, before concluding, a word about CORAD's classification. So, many of us may come across with CT report saying CORAD's classification. Does that indicate the severity? No. It indicates level of suspicion. So, you have a suspect case and you're taking imaging. You're getting features suggestive of COVID. For that, you can go for CORAD staging. So this was devised by the Dutch radiologist and it was used in Netherlands in areas of high prevalence of COVID, those who were not positive. So it's just like BIRAD system for breast CA, where you have 0 to 6, 6 being the biopsy proven. All other grades, 0 to 5, from the radiological imaging, you're giving a suspicion. Okay, it could be positive, it could be benign, it could be normal, just like that. Probably it is a COVID positive, very unlikely case like that. So it is a level of suspicion. So to assess severity, you have CT severity score. What do? We divide the lung into lobes. 3 on the right side, 2 on the left side. For each lobe, you look at the level of involvement, the extent of involvement. Grade it, sum it up, and out of 25, you're going to give a score. So that's all basically about the role of imaging, basically X-ray and CT in COVID-19 with respect to the pulmonary manifestation. So by the end of this, I think all of us are aware of what is expected finding in imaging, when should you go for imaging, and which is the preferred modality of imaging. Thank you very much.